So the plan, as Sophia said, was I'm going to give a 5-10 minutes talk, very brief, not going to go into details about diagnostic accuracy studies. And then we talk about the paper, we discuss the paper in small groups, and then Swan will wrap up and go over the general findings of the paper. Yeah,
okay. Yeah, you got it. Sorry.
All right, so for every research question, we need to have a proper design to address that research question. For a therapy question, you only pay attention to RCT, randomized controlled trials, yes. For diagnostic accuracy, you need cross-sectional studies. And cross-sectional means basically within a specific period of time, you enroll everyone and you do the index test and gold standard on everyone. Like within a month, anyone with PE gets the D-dimer and the CTA. Everyone gets the index test, everyone gets the gold standard in a period of time. And the benefit of cross-sectional study is, first of all, everyone is enrolled, everyone with the target disease that comes in that specific period of time gets enrolled, plus you can calculate the prevalence of the disease because you're enrolling everyone. There's another way of doing this, it's called case control study, and you go back, you look at people who had the gold standard and then go back and see who had the disease, who didn't have the disease, you match them by their characteristics and then compare their findings. It's not ideal. We shouldn't be looking at this one. We want a cross-sectional study, and that cross-sectional study is a way of sampling, a proper sampling for a diagnostic study. Gold standard obviously is the main issue for diagnostic studies. An ideal gold standard should be it's available, it's cheap, and everyone can get it, right? If your gold standard is a aortogram, that's going to be a problem, right? Because it's invasive, you can't do it all day, and you need specific specialties to do it. But some other gold standards, like maybe CTA for PE, that's something that's more readily available, it's relatively cheap, it's doable. It has to be definitive, right? Autopsy is one great gold standard. That's a joke. Some gold standards are not definitive. For example, what's the gold standard for diagnosing seizure? EEG, right? Do you know how many times or in what percentage of times two epileptologists agree on the finding of an EEG?
0.
About 50 to 60% of the time. So you can give the same EEG to two neurologists and they only agree with each other in about 60% of the time. So that's not an ideal gold standard because it's not definitive. But unfortunately, in case of seizure, that's the only thing that we have. So if your gold standard is definitive, that's great. Relatively, for the Doppler ultrasound for DVT is relatively definitive. Relative. And again, it has to be done on all patients. So since we are going through this paper, that's a diagnostic accuracy paper. Just want to talk about what a good diagnostic accuracy paper design will have. First of all, the design has to be cross-sectional. The gold standard should be definitive. Everyone should get the index test and the gold standard. As when you read diagnostic accuracy papers, when the gold standard is not readily available, some people get the gold standard, some people get other way of reference standard. For example, some people get CTA, and then if they don't get CTA, you follow them for 30 days and call them to see if they had any evidence of PE or they need to be hospitalized for PE. So there are more than one way of doing gold standard. Sometimes for like CHF studies, there's really no gold standard for CHF diagnosis. And most studies, they do adjudication. So some experts look at the BNP, look at the echo, look at the other things, and they decide that this patient has CHF. So the more definitive the gold standard, the better the accuracy study is going to be. And of course, you need to enroll a wide spectrum of patients. You have to, the paper has to assure you that people with mild disease, moderate disease, and severe disease were enrolled in the study. If the study design is in a way that people with high risk of the disease are only enrolled, or people with mild form of the disease are enrolled, you're missing that spectrum of patients, and the accuracy of the test might vary between based on how sick the patient is, right? So if, let's say, you want to test a new flu test, and you only do the test on patients who go to outpatients clinic, you're going to miss the patients who are really sick and come to the hospital and get admitted, right? Or vice versa. If you only do it in the hospital, hospitalized patients, you're only testing people with severe influenza, and you're going to miss the patients who are who don't have this serious form of disease. So pay attention to the spectrum of the disease, and look in a paper, look for any indication that because of the enrollment or sampling, they might have enrolled patients who were more obvious to have the disease and might have ignored people who had lower risk of lower probability of disease. For the endpoint, for the outcomes better be diagnosis. You want to know whether the disease is present or not present, right? Dead or not dead. For the test results, you can have non-dichotomous. The test result could be continuous, like BNP. It could be a number that has continuous variable. It could be multiple outcome, like BQ scan gives you low probability, moderate probability. That's okay. Or it could be dichotomous with, like corona present, not. The tests have to be reproducible. So if there's an ultrasound test, if I do that ultrasound test and Kilpatrick does the same ultrasound test, we have to be able to get the same results, right? Or if they report how the test was done, some other people have to be able to reproduce the test and get the same results. Blinded interpretation is probably the most important aspect of the diagnostic accuracy test. I apologize to ultrasound people because I always give this example. Just imagine, the ultrasound team shows up, 10 o'clock gingerly after they had their breakfast, and they say, do you have any patients for ultrasound? And tell them, hey, yeah, that guy 2 probably has shoulder dislocation, right? They go to ultrasound the patient and they say, yes, there is shoulder dislocation. And then somebody decides that, when a fellow says, I'm going to publish these results. And they publish it, and you get 100% sensitive, 100% specific ultrasound for shoulder dislocation. In fact, I had a paper that was submitted to me as an editor of AEM that showed the calculated likelihood ratio for ultrasound for shoulder dislocation was 600. A likelihood ratio of 600. It doesn't exist in any other diagnostic test. But it's because they first of all, they're not blinded to the findings, and they look exactly for the findings of shoulder dislocation. So blinding for diagnostic accuracy studies is extremely important. If someone tells you that this patient had Doppler ultrasound and it had DVT, and then you are doing the ultrasound to do the DVT, you're going to find the clot, right? So blinding is extremely important in a diagnostic accuracy study.
Wasn't that just published in the annals? Secco. Dr. Secco.
Sorry, I didn't mean to. And the findings of diagnostic accuracy study has to be has to help you in clinical decision making, and we'll talk about this. So quickly, I don't want to go through details of this test characteristics, but the first two, sensitivity and specificity, are not really helpful in clinical decision. They are test characteristics, right? They're not. If you know a test is 90% sensitive and you do it on a patient and it's positive, what is the probability of the patient having the disease? It doesn't tell you. Sensitivity tells you that if the patient has the disease, the test is going to be positive this number of patients. Or if the specificity tells you if the patient doesn't have the disease, the test is going to be negative in this percentage of patients. In terms of clinical decision making, sensitivity and specificity don't help. But it's a good information to have. So diagnostic study has to report sensitivity and specificity, or they have to give you the numbers that you can calculate it yourself. What helps you really with a diagnostic test is likelihood ratios, because they tell you if the test is positive, how much is going to increase the probability of the patient having disease, right? So you have a pretest probability that usually based on prevalence of disease, and then you do one test, and if that test is positive, it increases the probability of the disease to 50-60%. And then if that's not, the good thing about likelihood ratios is you can do more tests, and tests doesn't mean just lab. It could be physical findings, could be elements of history. So you can build on this pretest probability until you get to a point of that the post-test probability of disease is high enough for you to start treating the patient, or it's low enough for you to stop testing and rule out the disease, right? Do you know what number do we usually look for post-test probability to start treating, or what number do we look for low enough to rule out the disease and stop testing probability? Let's say you have a disease that you want to start treating. At what probability do you consider the patient to start treating? It depends on the disease, right? So if your test is telling you whether the patient has malignancy and you want to start chemotherapy, you better have a probability of at least 98% to be sure to start the treatment. For a UTI, you probably can start treating the patient with a probability of 80%, right? So it's the disease dependent. If you are ruling out, myocardial infarction, you want the post-test probability to be less than 2% or even less than 1%. While if you're looking for, ankle sprain, a post-test probability of less than 10% is enough to stop doing anything else, right? So going back to likelihood ratios actually help you make a clinical decision. It tells you how much the probability of the disease is going to increase or decrease based on the test results, and you can apply multiple tests. So you have one test, you calculate your post-test probability, and then that new post-test probability is a new pretest probability when you apply the second test. So this is an example. So imagine a young woman without history of UTI and with no medical problems comes, and the patient, the pretest probability of a UTI is roughly 5%. That's the prevalence of asymptomatic UTI in young women. So your pretest probability is 5%. And then your first test is whether dysuria is present or not, right? If the patient said she has dysuria, that's a test. And the presence of dysuria based on the likelihood ratio increases your probability to 70% probability of UTI. And then you go to the next nomogram, and then if the patient says that she has back pain, now the new test increases your probability to 90%, right? So at this point, I have a post-test probability of 90% for UTI. Do I need a UA to tell me whether the patient has UTI or not? Probably not, because a negative UA doesn't. It's the likelihood ratio of negative test for a negative UA is not that great. So at best, it might drop the post-test probability 98%. You're still within the treatment zone. And then, so at this point, you can start treating patients based on the probability that you have. And then this last one is if the absence of any vaginal discharge or vaginal complaints increases your post-test probability even higher. So the beauty of likelihood ratio is you can incorporate that in your clinical decision, and you can apply multiple elements of history and physical examination. So going back to diagnostic accuracy study, they have to give you the likelihood ratio, or they have to give you the numbers for you to calculate likelihood ratios. So the question for seniors, where do you get your likelihood ratios? And what you say might be used against you. Noah.
I mean, from like which table?
Where do you get your likelihood ratios? If you in the clinical area you have a question and you want to know what the likelihood ratio for a test is.
I mean, I think when I calculated them myself, I'll go to the paper itself and then put it into like a.
Really, do you have time to pull out a paper and calculate like?
You go to NNT.
Who said that? The correct answer is theentity.com. So this is a shameless advertisement. So it's actually, you can quickly go to NNT.com and for NNTs, this is an example of an NNT for aortic dissection, and we highlight them by color. So if they're gray, the likelihood issue is useless. It doesn't change your post-test probability. If it's dark blue, it does change your post-test probability. So if you click on the dark blue, you get something. You get something like this. Then it's a calculator that actually tells you that if you have the test, what your post-test probability is going to be. Isn't that beautiful? So anyway, NNT.com is available if you want to look at likelihood ratios. That's probably a good option for you to check likelihood ratios in the clinical area. Probably the best option is what Noah said. If you have time, go to the paper, go to systematic reviews, look up the likelihood ratios. But this is a quick way in the clinical area to look up the numbers. And then the biases, I leave the biases for Suam to talk about. Any questions about the design of a diagnostic accuracy trial? So remember, look for the design. The design has to be cross-sectional. Make sure the people who do, first of all, the index test has to be done on everyone. Gold standard should be done on everyone. And people who do the index test or the gold standard test should be blinded to each other's findings. And the spectrum bias. Make sure everyone with mild to moderate to severe disease is enrolled to avoid the spectrum. Okay, so now we can
do the breakout.
Read the paper, talk about the potential biases, and then after that we'll talk about what biases this study has.
Just read the method section.